Welcome, everyone. We appreciate you all joining us. Today we have Dr. Leslyn Keith here with us. She's going to be kind of talking about her latest article that came out about Dr. Keith. Leslyn Keith is a certified lymphedema therapist and has a clinical doctorate in occupational therapy with an emphasis on lymphedema and obesity. Dr. Keith has started 4 lymphedema therapy programs in California, including 2 in private practice. She has treated lymphatic and fat disorders for over 20 years and currently researches, consults, and lectures on lymphedema, lipedema, obesity, both national and internationally. She is the author of 2 books and published several articles on the efficacy of the ketogenic diet for lymphatic and fat disorders. Currently, Dr. Keith is a consultant with the Lipedema Simplified LLC and lymphedema seminars, an instructor in lymphedema therapy for Klaus training, and directs Lymphatic Lifestyle Solutions, an online course both in community for management of weight and lymphedema. So we really appreciate you taking the time to join us today. You have the article, and I'm going to go ahead and pull up the PowerPoint for everyone to see. So let me just kind of, like I said, bungle my way through that real quick.
Mhm.
Okay, so the article on the proposed framework for the research case definitions for lipedema. We asked our members to send in some questions. I think we actually got some really good questions, which is awesome. So the first one that we kind of organized is, what motivated you to start the process of establishing a case definition for lipedema?
Yeah, and it was really to improve the strength of research about lipedema. It's been a topic that is really much more popular, and researchers are really looking into this condition. And it is difficult to have really good research performed when everybody has a different definition of what the condition is. And so we wanted to be able to aggregate data. If they're both looking at cavitation as a treatment for lipedema, well, if they defined lipedema differently, you couldn't really pool that data. So that was a primary motivation, is that we really felt like that there needed to be some criteria that could be applied universally to research projects. And then hopefully we would be able to do something like that, aggregate data, do meta-analyses and systematic reviews.
So I guess my personal question is then what motivated you all to do it? Because
Mhm.
like that's a big undertaking trying to define a diagnosis essentially.
Yes,
So was
yeah,
it just that we reached the point of we're to
yeah,
this point where we need to have it now and someone's got
yes.
to do it?
Yes, and really, I'm always interested in research myself, and I was primarily looking at lymphedema, but then I kind of got pulled into the lipedema world mostly because of nutrition, and then one thing that I noticed is that there was a lot of limitations on most studies that were looking at lipedema: small sample sizes, lack of a control group, lack of a definition of what was your inclusion and exclusion criteria. And so I became concerned about that. But at the same time, there was just more and more and more papers out. And so Catherine Seo, Dr. Seo, originally started collecting articles because she was trying to figure out what was happening to her. This was her own way of doing research. So she started collecting papers in her Zotero platform in 2013. And then I met her in 2015, started working together in 2016, and we started, I'm just interested in, I like reading research papers. So we just started anything that had the word lipedema pop up, we would be putting that into the bank. And then by 2020, it was just something that the condition was talked about so much, and everybody had differing opinions. I know you've probably seen some of the more contentious papers coming out, some different arguments going on in the field. And so we really felt like, in order to move forward and to really figure out what's going on here and to have a plan to improve the lives of people with lipedema, we need to define it. We got to start with defining it. And so that's what motivated us to get started on that. And then we ended up getting 10 authors, international authors, that joined us on the paper.
Yeah, that's absolutely incredible. So I feel like sometimes we forget that we're even though like I'm in my little world and you're in your world and things that ultimately we're in something that's a little newer and it's still universal, it's still worldwide. Women
Yes,
everywhere
yes,
deal with this condition, even though it's my women in my area that I'm working on directly. And I guess
yes.
that kind of I had lost that perspective until I was reading the paper and then I was seeing all the contributions and things. I was like, oh wow, that is a lot bigger than I thought it was going to be when I first opened it up. So
Yeah.
okay. So the article noted that the Sotero library was started in 2013. Is that when your team decided to start this framework essentially?
Yeah, and as I was saying, that's when Catherine, Dr. Seo, was started compiling data. I mean, she went to the Foldy Clinic and got everything they had in their library and put it into her Sotero because she's trying to figure out what the heck is happening to me. And the Foldy Clinic was one place that really was looking at lipedema and doing treatment for lipedema.
Yeah.
And so that it was her project, and she started putting that together. But when she and I started collaborating, we really wanted to promote research. This is the way we can figure out what's going on.
Mhm.
So we wanted to promote that, and one way was to define it, define
Yeah.
the condition.
So I guess another question kind of tacked onto that then is where did you all draw the line? Like what brought you to draw the line before you started really constructing the framework?
Draw the line as far as what papers to include. Is that what you mean?
More when to stop, waiting for the next, research,
Yes,
next
because
piece.
we published in 2023, and we have some papers that were in 2023
Uh-huh.
included in there. And that's it's so difficult, especially in another project I'm working on right now, as I told you, a textbook about lipedema. And we have authors contributing different chapters on different topics. And they all are waiting to wait a minute, there's another paper that's coming out just on my topic and I want to include it. And so it's hard to get them to get their chapter submitted because they know that there's something about to be published.
Mhm.
So we had to just we told everybody we've been doing this for 3 years. Let's get it done. And this is where, we kept saying, this is the last time we're sending it around for your approval. And then you do it 10 more times after that. But we really, we put a deadline that we wanted to get it done by 2023. So let's get it done. And we did, but it's very hard to draw the line.
I'm sure, especially where you all were able to take so much data and kind of compile it. I guess you're always waiting, especially looking at some of the factors in that article and some of the lines. I guess I would always be looking for, oh my gosh, the name is escaping me, the kind of the blood components and things like that, just
The
waiting for,
labs, yeah.
yeah, I would love something to kind of boost this from moderate to more like to more higher efficacy and stuff like that. So I,
Yes.
I
Yeah.
guess I guess you do have to draw the line somewhere to be like, that's it, we're done.
Yeah. Yeah. Yep.
Okay. So the next question was it an intentional decision to publish this article the same year as the Lymphedema Treatment Act that went into effect?
Well, and the Lymphedema Treatment Act took a little bit longer than we did to get our paper done. We only worked on it for 3 years, and I think it was over 10 that they were trying to get
Mhm.
that act passed. So I never even thought about that. It was purely coincidental, but a lot of wonderful things happened in 2023,
Mhm.
and that was not intentional at all. It just that they just both happened then.
But I do think it's great that it really highlights it's not just lymphedema. And
Right.
down the road, because these patients need that same care that we provide our lymphedema patients, I think
Mhm.
the fact that it came out around the same time was able to bring a little bit more awareness for people, which was nice. And then the fact
Yes.
that we're having a textbook come out that
Right.
in some ways kind of makes it much more official to have its own official book dedicated towards treatment and diagnoses and things like that. So yeah, actually
Yes.
awesome coincidence at least. That's great.
And we're getting the World Health Organization is putting out an international code for lipedema. So I don't think that our IC codes have got a lipedema one yet in the US, but we're hoping that's around the corner because we now have an international code for it. So a lot of things are coming up that I think are going to improve access to care and proper treatment and timely treatment for patients with lipedema.
That's awesome. Did the paper that the proposed framework, did that help move forward with the ICD or the World Health Organization's code essentially?
No, it didn't, but all these things promote awareness of lipedema. And one alternate use for our paper that we're really excited about is that a clinician can have that paper and they can diagnose lipedema. If you're an MD or something like that who is able to diagnose it, because our paper says, here's a criteria, here's how you test for it. And so it lays it out. And so what patients are doing is they're bringing that paper to their physician saying, okay, now can you help me determine if I have lipedema? Because it does lay it out easily for the healthcare provider. So we're excited that with that unintended purpose has happened.
That's
I
awesome.
actually have a little comment that I actually gave one of my patients this paper because she didn't have a diagnosis. And I'm like, I can treat you, but it would be great to have a diagnosis. And she did bring it to her primary care and they did write us a script. So
Wow.
that's actually awesome use of
Yes.
like that's coincidental, but it's great that you think it's a good idea too.
Yeah.
Yeah. I just think I mean, the whole thing was to, improve the research so we can learn more. But if it can also improve awareness and allow people to get diagnoses, you have to have the diagnosis to have treatment. And in some cases, I mean, I think there was one published paper that said 17 years is the average that someone figures out there's something wrong with me before they get a diagnosis of lipedema. That is too long to wait. And so we're hoping that this paper will increase that awareness and help a physician make a diagnosis.
Yeah, definitely an excellent step in the right direction, that's for sure. So the next question was, how did you all decide on the alternative suggestions for inclusion criteria?
Yeah, and so I'm thinking this is referring to how did we figure out to put additional evidence, using those criteria, what made us do that. And there is, in the paper, we talk about what criteria we used to say this is an agreed upon evidence. It had to be reported consistently over time, and consistently it's said a certain way over time, or if there's conflicting evidence, there is not a plausible reason why it couldn't be lipedema, or and I'm forgetting what it was, even if there's something conflicting evidence, the preponderance said that it was lipedema. So and so if we didn't have enough to make it be agreed upon characteristic, but we thought it was pretty important and reported often, then we're going to put it in the additional evidence category. But it also might be there just because the criteria is not seen in every patient with lipedema. For instance, like the ankle and wrist cuffing. Well, if your lipedema tissue does not extend to your ankle or wrist, you're not going to have that criteria. And I don't want to have a false negative. I don't want to say that you don't have lipedema because you don't have the ankle or wrist cuffing. And so, I mean, our sample sizes for lipedema studies are small enough already. And so I don't want to turn away participants because I've given them a false negative. And so, we wanted to have these other criteria in there that if you, it's automatic, you're in the study if you have all 5 of the agreed upon characteristics, but maybe you only have 4 of the 5. There should be a way for you still to get in the study if it can be substantiated that you have lipedema. And by using those additional evidences that just aren't as strong, then that can help bolster the opinion that you indeed have lipedema and you should be part of the study.
So when you all decided on, like, for instance, you have four of the agreed upon, was there something specific about having two of the suggested, or was it just by having two, you've narrowed down the likelihood of a false negative?
Yeah. So first, if you don't have all five, you only have four, it has to include female and it has to include pain. And this really came from our discussion with our European authors. They felt very strongly on that. Yes, there is some males. Yes, there are some children. Yes, there are some transgender, but the majority of the papers are written about female. So we needed to have that be a criteria. And there are other fat disorders that don't have any pain and have a different diagnosis. So they really felt very strongly that there had to be a pain diagnosis. And we convinced them that it should be current or historical, because if you've had successful treatment that it was able to reduce or resolve your pain, you still have lipedema because you still have the disproportion, you still have the skin and tissue changes, you still are unresponsive to traditional weight loss diets, then you still have lipedema. And so they agreed that it didn't have to be current pain, but history of documented pain. So those two had to be there. But then we may not have disproportionate distribution of adipose tissue because you also have obesity. And that's going to disguise the disproportionate thing. So we didn't want to, again, have a false negative because we required that we had that disproportionality. You may be a young woman of only 18 years old and you really haven't tried a lot of diets, so you don't know if you're non-responsive to a diet. So we realized that, again, our sample sizes are already so small, we couldn't just require that you had to have these five, otherwise you're out. And there was so many other properties, characteristics of lipedema that are in the literature, such as those listed there in the additional evidence, that we really felt that, and you can see the combinations. If you have four that include the pain in female, then you only have to have two from the additional evidence. You may have more, but you only need two from that right-hand column. And then the third pathway was that you only had to have three of the agreed upon, but then you needed to have, what is it over there? Yeah, but with four characteristics. Again, we want to make sure that it really is, we don't want to have false positives either. And that's when our whole discussion about sensitivity and specificity is, that we want to get true positives and true negatives. So when we're compiling our groups for research.
And I believe, if I remember correctly, there's a question about that later on.
Yes.
But just so, since we're already on it, what would it take to then use that criteria to create a sensitivity and specificity? Is that something that you've all talked about for the next the project?
Well, I think I'm looking at, for that one question that we're talking about. So the sensitivity is, we want to have a high rate of true positives. We have a test or criteria that says that we are pretty darn certain that everybody we have in the lipedema group actually has lipedema. So we want to have those true positives and a really low rate of false negatives, that we don't want to exclude people who actually have lipedema. But then the specificity is that we want to have a high rate of true negatives. We have identified people who do not have lipedema. And that specificity also is, you have a low rate of false positives. You don't want to have people that in the not lipedema group that actually have lipedema. That kind of problem can really screw up your data and your results. So to try to do that, we are, again, when we have this framework, it helps us try to get to the highest possible sensitivity and specificity, because we are not requiring that you have to have all 5 of those criteria, because we know there's issues with that. And we're going to end up having very small sample sizes. So by allowing alternate pathways to successfully be in a either lipedema group or not lipedema group, then we're going to increase our chances of having high sensitivity and high specificity.
Yeah. I am a little ashamed to say that when I was reading the paper, the level of thought that you all put into that, I mean, clearly it's a parent talking, and now that you're highlighting some of these on making sure that we're correctly diagnosing this, we're correctly ruling out the individuals who don't have it and things like that. It didn't really register to me how much you all had put into such a solid definition with the goal of let's not just define it, but let's define it so that we can start building, like you said, ultimately a framework, which is what the paper is really proving. But it just shows that you all put so much detail into it and gave so much consideration for the entire spectrum of it, which is impressive.
And it's meant to be a living document. This is not, that we've just put this down in law and this is what it is, because I'm sure we're wrong on some things. I mean, and when the initial paper came out in 1940 from the Mayo Clinic, we've changed since then. Our opinions on things have changed as we're able to do imaging and all kinds of studies and stuff like that. We're learning more. And so this is really meant to be something that should be updated. It should be discussed and argued about, as we did when we were putting together the paper. That needs to be a continual process, because this can't be just something you set in stone and that's okay, we're done.
Yeah, just drop the mic and walk away from it, I guess.
That's right.
Okay, so next question. Oh, that was actually the sensitivity specific. I knew it was coming up. I'm just glad I was on top of it.
Yeah.
What other characteristics do you see becoming agreed upon characteristics or additional evidence features for the future?
Mm-hmm. So I'm looking for my notes on that, because I was looking at, there was some we had some great ideas that we put in there, but also some other things that I think would be good to look at. So it would be great to continue the work that has already started on the genetics of lipedema. So it seems like there is a family, a history of it. And so there could be genetic, but it's, again, how do you study the genetics if you haven't really defined the condition? And so I feel like this framework can help us now continue to work on genetics. Also, I think, as we were talking about earlier about biomarkers and blood work, gosh, it'd be wonderful to confirm a diagnosis by a blood test. And there does seem to be some patterns and some associations and some tendencies, but due to the poor reporting and no consistency on data collection, it's really hard, again, to really make any conjectures on what's been found so far. But I would love more research being done on that. There is anecdotal reports in the lipedema community, and also it's found its way in a couple papers about abdominal and particularly gynecological surgeries being a trigger for the onset of lipedema. And so it would be wonderful to explore that further with research. Just like, it's often talked about that periods of hormonal flux, puberty, pregnancy, and menopause seem to be a very common triggering period. We need some more on that. And women are having questions about, well, what about birth control? What about hormone replacement therapy? If this is hormonally driven, can I do these other, expose myself to hormones in this way? And I just don't think we know enough about lipedema and hormones, and if there are different phenotypes of lipedema, because anecdotally we're seeing that some women respond really well to HRT, for instance, and others, their lipedema goes crazy with hormone replacement therapy. So more exploration on that. And then we don't have enough on children and males, probably because it is such a low incidence of identifying a male that has lipedema. And then we have a big problem with just identifying adult females, let alone identifying it early in a child. But it would be great to get more information about those populations. There's so many directions you can go in lipedema research, but you know, some of these might end up being added to the criteria as we learn more about those. I'm thinking about another one that's anecdotally that women talk about a period of really high stress seems to have triggered or exacerbated their lipedema. That would be something very interesting to research.
Mm-hmm. Yeah, it'd be interesting to find a way to quantify that too.
Yes, yeah, yeah.
Okay. When describing lipolymphedema, do you see a hybrid framework developing specific for that category?
And at this time, I don't, and that doesn't mean that it's not going to happen, but I think the current discussion is that these really are two separate conditions, two comorbidities that happen often together, particularly at the more severe stage of lipedema. Seems to affect some lymphatic failure, and lymphedema happens, but the person has lymphedema and they also have lipedema. And so some factions are saying we really shouldn't be putting these two words together. We should say that they have these two separate diagnoses. Treatment for them would still be CDT, complete decongestive therapy. But in places like the US, where we don't have a diagnosis code for lipedema, well, when they have both, they can get treatment because they have the lymphedema diagnosis. And if you give a lymphedema code and then you call it lipolymphedema, I don't know that you're helping the patient so much with that. So at this point, I don't see the framework changing to accommodate that combination of conditions. Yeah.
Okay. So, I mean, it does make sense. It's very logical when you put it that way.
Yeah, but I mean, it's definitely, it could be a criteria for a study. If you want to study people who have lymphedema and lipedema, if we have the two conditions very carefully defined, you can make inclusion criteria to make sure the participants all have those two conditions.
Yeah. Well, maybe in the future, we'll see.
Mm-hmm.
What tools do you use to demonstrate hypersensitivity or altered pain, given that many women feel their symptoms are actually normal?
Yes. And we discuss this a little bit in the paper, and it'll be discussed more in our textbook about lipedema, because you're talking about a population who may have been dealing with chronic pain for decades. And a very common, very useful tool is to sublimate that and to not feel that pain as much as possible, to ignore it, to not acknowledge it. And they may feel like, well, doesn't everybody have pain when they get a blood pressure check? And so when their doctor asks them about pain, they're, no, not really. And so you know, we'll typically use a visual analog scale, you know, 0 to 1. What's your pain on that scale? We might even use the Sims-Weinstein test for sensitivity in that way. And there was a good paper on that, by the way, on lipedema and using the filaments. But probably the most useful thing is to really have a conversation and allow the patient to use their words to describe their sensation. And they're going to have other words that are not pain, but they're heavy. It feels like my legs are a pile of rocks. You know, they'll have other words to describe what is probably pain. And it requires a conversation and really listening to figure that out if they have any pain.
Great answer to that. So that's unfortunately right where we are. The framework has been tremendously helpful, but where we are traditionally, it's been that conversation is how we've diagnosed these women in the first place.
Yes. Yep.
Are you using the case definition clinically in your own documentation?
So coincidentally, when we started working on this paper, I saw my patient in last patient in January of 2020. So, and then as you know, about 2 months later, we had the lockdowns, and it was very hard to see patients. And I didn't have that problem because I was already not seeing any, but I did use my experience up until that point to contribute to the paper. So I didn't have, I would have loved to have had this paper to help me clinically, because even though we're, as occupational therapists, which I am, I can't diagnose a person, but I can tell that person that you have characteristics that really look like it might be lipedema, and, you know, let's take this to your doctor and see if that's true. I wish I would have had that. But yeah, so I do think this will help clinicians.
I can go ahead and say from personal experience, I use it to a degree. I unfortunately don't think it's so ubiquitous that I can just leave it there. I wish I could just be like, oh, this stage with these characteristics, but frequently I'm able to use that to kind of, at least for my own documentation, organize my thoughts. So I'm making a very cohesive argument for lipedema, essentially, when it comes to the discussion on insurance authorization, compression garment approval for other things. So yeah.
Right. Yes, yes, very good.
What's the next immediate step after a case definition has been established? Is that something such as validation?
So this is an interesting thing here. So in order to, the next step after you've done a case definition is you want to start broad. And so you're going to start really broad with things like female and pain. Okay, but that's too many people that would fit into that definition. And so now you narrow it down and you get these other criteria like we've put on there. And then you want to compare all that criteria to a gold standard, a definitive test that says this is lipedema. As we know, that doesn't exist.
Yeah.
And unfortunately, in order to validate a definition, you have to be able to compare it to some kind of test like that. So this is impossible to have it validated, but it doesn't mean that it can't be useful, it can't be improved upon. So the next step would be to have this case definition applied to as many research projects as possible, so that now it's being actually tested. You're applying it to research projects, you collect all the data, and then you and you want to actually apply it to people that you know have lipedema. Does it work? Does it say they have lipedema? And you want to apply it to a whole bunch of people you know that don't have lipedema. Does it work? Does it say that they don't have lipedema? And so we're collecting all that data, and you can actually then calculate the level of specificity and sensitivity of it there. And then depending on how those calculations come out, you can adjust the case definition. We had one response so far to our paper where a group, I think it was a collection of physicians that are both European and US based, that made some suggestions. This is the type of thing and the way that we improve upon it is by having those discussions, but also by testing it and actually applying it to research studies.
So I guess the next question would be, if you have to be able to compare it to a gold standard, then are we looking for a standard, kind of like you mentioned, or like a actual blood test, something where it's that strongly quantifiable data that then we can use for the framework to say this is diagnostically how you lead to this next step?
Yeah, for instance, Dr. Roxon did a study looking at PF4, platelet factor 4, and he found that, and this says that there's some kind of lymphatic dysfunction. So it's very high in people who have lymphedema. And then when he applied it to patients with lipedema, he found it high there also, and it was not high in patients who had obesity. But there was not a good case of definition. So do we really know that the people in the obesity group, you know, maybe they had lymphedema, maybe they didn't also, maybe the people in lipedema group, maybe they also had obesity. And so we don't know that those groups were really clean, and also it was small sample size. And so, but this is the type of thing that we're looking for. We're looking for, is there a blood test? Is there a simple lab test that we can do that says, oh, this, we have lipedema right here. Next.
We can dream. It's always out there. We got bioimpedance in clinics, so maybe
yes,
that's
yes. Yep.
Given your extensive review of the research, what would you recommend to be the next steps? And I think you kind of touched on this a little bit, but just to kind of maybe summarize what you were saying earlier.
Yeah, but definitely there's still so many aspects of lipedema that we can look at, and we talked about those earlier. And if those ideas, you know, to pursue is stress triggering lipedema, is gynecological surgery triggering lipedema, for instance, if we use the criteria for good exclusion and inclusion criteria and get good sample sizes and also clean samples, I think we can really find a lot of information and really improve our knowledge of lipedema. Yes.
Would this case definition help promote the education of lipedema in academia across healthcare disciplines?
What a wonderful application of it. and actually something that we hadn't thought of. I do believe that if we can get lymphedema into healthcare education, then it'd be wonderful to get lipedema in there as well. Just for them to study the lymphatic system in education would be wonderful. So I do think that this kind of paper published in a well-respected journal and most of the authors are MDs. I mean, it does improve its acceptance in the field, and also people that are outside the field, but they primarily want to hear what other MDs are saying about something, or other PhDs are saying about something. And so I have high hopes that what this person asked, that this will come about. This is a great comment.
Yeah. So we actually we had another meeting a couple weeks ago, and we were discussing the differences in education across therapy disciplines, you know, coast-wise and things like that. I think it's even interesting when you extrapolate that into the physician, nurse practitioner, PA education, when you leave the therapy disciplines and kind of look at medical overall. Like, we all know that lymphedema itself is kind of woefully inadequate in education there. So we can only imagine how little lipedema is actually ever discussed. Do they even see it in a textbook anywhere while they're going through it? So, like, ideally, I like this question.
Yeah, there's so many aspects of someone with lymphedema and with someone who has lipedema that require all different types of disciplines. You know, women with lipedema are known to have a propensity for having weak muscles. Specifically, one study looked at the thigh. Well, that's going to need physical therapy. Women with lipedema have a high propensity for being low thyroid, for having hyperthyroidism. That would need an endocrinologist. So to have all these disciplines be aware of the condition is really going to enhance care. Yeah.
Nope. I guess the framework is a great start in that right direction then. Do you have any recommendations for clinical therapists that may want to get more involved in lipedema research?
Yes. And I do want to urge people to try. I have a couple recommendations for you. One is consider publishing a case study report. You have a patient who has lipedema and maybe some other interesting comorbidity. She has EDS or she has MCAS or something like that, and responded well to this or didn't respond well to that. Do a case study report. This is going to contribute to the knowledge out there. You don't have to, do a full IRB and recruit people and have $100,000, of funding in order to do a randomized clinical trial. You can just publish a case report. I really urge you to do that. And there are journals that are devoted to just lymphedema therapy. So consider that. And the other thing is, think about citizen science. Patients are experimenting on themselves all the time, and they figure out stuff that they tell us and that we can then share with other people. And so, always encourage them to experiment under the guidance, under the CLT's guidance, under their other healthcare professionals' guidance, but they can do their own experiments and learn something about it, and you can publish the results. We did this a little bit with Lipedema Simplified. We did a study, a citizen science study, where we had people, we said, let's see if exogenous ketones help with lipedema pain associated with lipedema. And we're going to give you can, fill out these different surveys prior to trying it. We have a company that's going to provide all the product. And then, so we gave them all these things they can do. Plus, we said, here's what we're thinking that you can do for yourself. Take it all to your doctor and make sure that your doctor says it's okay for you to do. But it was, they're not enrolled in a study. They are experimenting on themselves, and they're given the tools to assess how things are going with themselves. And then they report it to us. And so one of my colleagues, Siobhan Huggins, she compiled all of the data from, I think we had 6 or 8 participants that were doing their own individual experimentation. We reported on it at a conference. And right now, currently doing a citizen science study about, does CBD help with pain associated with lipedema? Again, the same thing. We gave them tools to assess how they're doing, something to give to their doctor to make sure it's okay for them to try this out. If anybody would like to do something like that, feel free to email me, and I can send you samples of what we gave for them to give to their doctor and things like that. You can do this. A CLT can do research that can be meaningful and help the field.
So I do want to highlight real quick, because I feel like in our APTA organization, we have a students and new professionals group. So it's really geared towards the new grads coming out and getting started. And I remember coming out, years and years and years ago. And research seems so unachievable at that age, because you're literally, you're reading this in school. So it seems so far away. But to just know that there's value in just that case study. When you're talking numbers, we need more numbers to validate a framework and things like that. It does not have to be one research study with hundreds of people. It can be many, many case studies utilizing the framework and then utilizing treatments and different things to kind of support that. And I think that's something that at least I felt that coming out of school, I was a little unsure of. And now that I'm out where I am and I meet and I talk to people who do research, which is a wonderful experience, you kind of pull back that curtain a little bit, you find it's much more doable, and it's less of a, you imagine like the clinical lab with people over top of lab tubes and things like that and writing down things on notes. It's literally clinical science, is you're doing it in the office with your patients. And so that's kind of, if that's something that someone has a desire to do, we're also able to help, reach contact for Leslyn as well, or provide just ground force troops to kind of help make that possible too. So don't hesitate to reach out, because it is something that we do need more of. That even that smaller study, we just need more of it. We need more of that data.
And you may have just been to a lymphedema therapy conference and you saw the laser And you go, wow, I wonder if I can get my facility to pay whatever it is, $4,000, $5,000 for that laser. So, oh, they're going to let me try it for 30 days. Oh, let me do a little study where I have this laser for 30 days and I'm going to document the results with my patients. And so it's just something that's going to be done in-house. It's only going to be reported in-house. And then I could tell my facility, look at this. This is the results I got. It's worth spending this money. So it's not necessarily you're going to be publishing this to go to the greater world. It might be something that's really useful for you to get tools that you can now use in your facility.
Yeah, that's awesome. So something I think all of us need to really consider, because unfortunately in the world of lipedema research, there's just not, we don't have those volumes. Like, so especially lymphedema doesn't have the volume
Right.
either. But when
Yes.
you talk about
Yes.
that subset lipedema, it gets even less. So yeah.
Yes. Yes.
Would you be willing to sell your next project, lipedema related or something else entirely? And we actually kind of talked about that briefly. I'll go ahead and flip to the next slide, which was
Well,
your,
I want to tell you about one thing.
yeah, go ahead.
Just happened last night, our Gold Coast CLT meeting where we have, all our local CLTs, we got together and we had a presentation by a woman from a thermography clinic. And she was showing how that could be used to monitor lymphedema. And another clinician, I looked at each other, oh, wouldn't that be cool to do a thermography prior to CDT and then again after CDT? So that might be a project I'm doing, not with lipedema, but it'd be cool with lipedema as well, because it's an inflammatory condition. That's what thermography looks at. So there's all kinds of ideas out there. Consider it.
That's absolutely awesome. Do you want to plug your book a little bit? What you are
Sure. So this
on?
is a book that I'm editing with Dr. Roxon and Dr. Seo. We're the editors on this. It is a textbook, Lipedema Principles and Practice of Diagnosis and Treatment. We have contributors from all around the world, experts, Dr. Dudek from Poland, Michelini from Italy, Dr. Gabriele Ferber from Germany, all participating and contributing chapters in this book about all aspects of the condition and treatment. And we're going to be, of course, including our information on the framework for coming to a diagnosis of lipedema. We hope that it will be a text that can be useful to the clinician. And I'll tell you that lipedema patients are very excited about information and they'll probably be buying the book too. And this is the text that should be out in October of 2025. And then we'll have a companion book, because this is a kind of a dense text, but we will have a companion book that's a handbook for diagnosis. So a quick referral guide to make the diagnosis and send your patient on to where they should get treatment and what treatments to get and stuff like that. So expect those coming out later this year, and you can pre-order on Amazon.
It is an excellent idea in addition to the book. So we just, I mean, that's such an area that we struggle in when it comes to just lymphedema, let alone our lipedema as well. Okay. So I have been monitoring the chat. I haven't seen any additional questions or anything like that. I've also not received any additional questions from the forum that we did where people could send anything in. So is there anything else you would like to add or anything to this? Because I mean, it's been great having all this information, but just, keep bringing that wisdom on. I'd love to hear more.
Yeah, I mean, yeah,
Sorry.
go ahead.
Can I ask a question? So,
Yes.
I always wonder, what is a successful treatment for a lipedema patient? And it's like it's different for every patient, and I know
Yes.
goal specific is what you want, but
Mhm.
in your view, what would you call a successful treatment for a lipedema patient?
Well, and it really depends on what they want. With that criteria of pain being part of what's going on, usually what I've seen is that is bar any other wonderful things that happen during treatment, if their pain reduces, they've considered it as a successful treatment. So I would really focus on what can you do to reduce the inflammation and reduce the pain. Just pull out all of your various tools you have in your toolbox and see what can be done with that. It's generally, you're not going to see a huge volume reduction. Okay. And also, I think that the CLT is instrumental in their really the patient's cheerleader, their support system. They're the one that really understands what they're going through. Their family may not understand, their friends may not understand, but you as their CLT, you're giving them that emotional support. They're with you for 45 minutes to an hour, and that is their time. It's something that they get to work on for themselves. So I think that's a very important part of the treatment. And so there's a lot of lymphedema assessments that you can apply to the patient with lipedema, and then get that feedback on how successful they felt the treatment was. Was it this worth it to them? And I would say that most often they are feeling it's very much worth it, coming to get treatment with you.
Yeah, I feel like just for patients being validated that you have
Yes.
a condition
Yes.
and we can help you in some way, they
Mhm.
feel a huge relief. Even
Yes.
just like getting supportive garments that can support them and kind
Yes.
of
Yes.
decrease the pain helps.
Mhm.
And some patients even like they don't know some new studies have come up with like why exercise and strengthening and resistance training can be helpful for
Mhm.
lipedema. I just
Mhm.
saw a patient and she's like, yes, I've been doing strengthening exercises. But then I was like, show me what you do. And that was like, no, this is all like what muscle are you trying to strengthen? So even just giving them that piece of like what is strengthening, what is
Yes.
resistance training, patients don't know. So
Yes.
I feel like that can be helpful for patients. But thank you for answering that question.
Yeah. Yeah.
So that actually kind of sparked another question. Um, East Coast wise, at least I feel in my area, I'm seeing more people seeking surgical intervention
Yes.
than I feel like more in 2 years than my entire career before then.
Mhm.
I don't know the rumor mill we have in the or the saying we have in the East is it's in the West for 10 years before we even get it or we even start hearing about it. It's on the West Coast area. So I don't know if that's actually true or not. But in terms of the framework that you've developed, is that something that you've had plastic surgeons actively involved in? Because at least in this area, plastic surgeons would be a good place to kind of start utilizing that. They're already getting the patients, so it's a great way for them to kind of start putting that in their data as well.
Yeah. So Stefan Rapprich was one of the authors. He is one of the first people that was doing liposuction surgery for lipedema in Germany. And so, yes, he was definitely part of that. And collectively, our feeling of the authors is that surgery is part of it. It's not necessarily for everyone. So there needs to be education on who is a good candidate for surgery, who it might be more risky for surgery, and what is the best way to prepare yourself for surgery and treatment and support after surgery to promote healing. And so it's not just something that you find whether or not you have coverage, you go and do, and then you're done. It is a long process. But definitely part of the equation for many people with lipedema and others not so much, but something we should talk about. Yes.
Mhm. Yeah. So, okay. Well, I do want to say a huge thank you. I really appreciate it. This paper came out and it's something that's now in my stack that when I have people who don't know anything about their condition, like Ms. Renjin was saying, it kind of goes into their education on, I don't expect you to know everything that you're reading on here, but at least look at it and see that A, your concerns have been recognized and put on paper format. So enough people are feeling it. I mean, I give them resources kind of similar to what you're participating in as well. But not only thank you for your time today, but thank you for all of it because, like I said, this is a huge undertaking. This is a group of people that have been underrepresented in the research and in the literature. And so to at least be able to say we have a definition now to build off of, people can do case
Yes.
studies now and build on the research. And it's really
Yes.
created an opportunity for growth in that area.
Yes. Thank you so much for having me. It's been a pleasure.